Good morning, everyone. It's my great pleasure to welcome everyone to the first ANZVASC patient webinar, which coincides with World Vasculitis Day, which was not a coincidence. My name's Dr. Jessica Ryan. I'm a kidney specialist. I work at Monash Health in Victoria, and it's a very cold and windy day today in Melbourne. We've got people from all over Australia and New Zealand as well that have joined us today, so thank you very much. I'd like to thank everyone for taking the time to join us, and we have four fantastic speakers. First, a disclaimer. We're unable to provide any specific medical advice about your individual situation, so if you do have specific questions, please ask your doctor. However, we are able to answer some general questions. This session will be recorded. If you like, you can turn your cameras off. Your image won't be recorded, and please stay on mute throughout. Questions we'll be able to ask via Slido. So to use Slido, you can either scan this QR code now using your smartphone. So I'll give everyone a second to do that. I will also put it in the chat, the URL down the bottom. Also, you can use the Zoom chat to ask questions. We will answer the questions at the end of the session. Going back to the overview, we'll do our first two sessions first and then have a 10-minute break and then do the following two with the question and answer session. So if we give everyone just one more second to get that QR code. I'm going to stop sharing my screen and I'll introduce Professor Richard Kitching. So Richard is the current chair of ANZVASC. He's a clinician scientist at Monash Health in Victoria, which is where I work as well. He's going to give us a kick off the session by giving us an introduction to what is vasculitis. Thank you, Richard.
Okay, thanks, Jess. We'll just do this and hopefully everything will be underway. Let's find out. Okay, tell me, anyone, Jess, for example, if you can't see that. I think I can see it.
We can see it all great.
Beautiful. Okay, so look, this is I was asked to talk about what is vasculitis for an overview, and I guess it's pretty broad, but hopefully most of you can get something out of this. I will be pretty basic in what I'm talking about, so I do apologize to those of you who are already more advanced in your understanding, and I'm happy to take any questions about things after the session as well. Now, I guess the other disclaimer is I'll often refer to one type of vasculitis, not always, but often, and that's called ANCA-associated vasculitis, and some of you, I think, will have that condition. It's also known as GPA, MPA, or EGPA. So just remember, when I'm talking about a particular type of vasculitis, it may or may not be exactly what you've got, but the broad principles are overall similar. So I guess the question would be, what is vasculitis? And I always think the medical terminology is difficult, but also sometimes instructive. And so whenever we say in medicine itis, we mean inflammation somewhere in the body. So pyelonephritis is infection of the kidney. And most inflammation in the body is due to infection. And so in a way, without wanting to get too sidetracked early on, this is perhaps one of the reasons why some of you may have had a delay in your diagnosis, because if you think about viral infections in general, like flus and upper respiratory tract infections and other types of infections, they're really pretty common. But luckily, vasculitis is quite rare. So a general practitioner might only see one or two new cases of ANCA-associated vasculitis in their lifetime, but they'll see many, many cases of infection. Anyway, itis just means inflammation, and most inflammation is due to infection. However, vasculitis is not caused by, except in uncommon situations, by direct infection of blood vessels. It relates to inflammation of the blood vessels. So it's the immune system malfunctioning and causing small blood vessels that carry blood to and from the body to malfunction. Sometimes it can also involve large blood vessels. And this condition is often, but not always, autoimmune. And 10 years ago today, as luck may have it, a group of people met in Chapel Hill in North Carolina to revise the classification of vasculitis. And because we still don't know exactly what causes all these forms of vasculitis, a pragmatic and reasonable type of classification is on the basis of how big the blood vessels are involved. And you can see on the left there, there's big blood vessels, the red ones are the arteries leading to small blood vessels and then into bigger veins. And you can see you can sort of group them into types. There's the ANCA-associated vasculitis, the thing that I'm particularly interested in, but you can also get small blood vessel vasculitis caused by or associated with direct antibody, that is to say fighter, deposition or presence in the blood vessels themselves. And then there are larger blood vessels that also can be involved. And I guess on the right, it just shows you the large vessels are the kind of ones that take blood to and from the organs and the tissues. The medium blood vessels, this is the kidney as an example, are kind of the ones inside the kidney, kind of like the early branches, sort of the big branches, but not the trunk of the tree of blood vessels. And then the small blood vessels, again, using the kidney's example, those tiny little red dots, about half the size of a pinhead, are actually a ball of small blood vessels that are in the kidney allows filtration to occur. Of course, not all small blood vessels do that. That's a specialized blood vessel, but this is the principle that we work on. Now, why am I showing you pictures of animals? I don't know, perhaps to break it up a bit, but also really to illustrate over time, over millions of years, how the immune system has evolved. Broadly speaking, we have two parts to our immune system. We have an innate immune system, which can often malfunction in vasculitis, but we also have what's called an adaptive immune system. And lower forms of life, such as sea urchins, have many, many immune sensors in their innate immune system. So they can sense danger, they can sense something's going on, they can activate fighters, but they're not very specific and they don't have much memory. These unusual things, I guess they're animals, in the middle are at the sort of threshold of a lot of evolutionary change in many parts of the body, but including the immune system. The one at the top is a hagfish, and the one at the bottom are lampreys attached to a fish. They're rather gross, really. But these have an immune system that have just started to recognize foreign invaders more specifically, but they don't produce antibodies. But following on from pretty much any animal with a bony skeleton, have what we call antigen-specific immunity, also called adaptive immunity. And so we're able to recognize things specifically, and that is in general a great advantage, because when we develop this adaptive immune system, meaning we could recognize proteins on bugs as specific, we could bring a lot more specificity. In other words, just attack the bug that's involved, not the rest of the body. It brought a lot of power to it because we could supercharge the innate immune system and do this. And it brought what's called memory. In other words, this is the basis of vaccination that you may hear about from Dr. Langeth later on. We get vaccinated and then we meet the bug later on. We've got a memory of having an immune system memory of this bug, and we can fight it without much or any infection. So really this adaptive immune system is evolved to say, this bug is not me and it's dangerous. Go on and target it specifically and powerfully. And by the way, remember what this stuff looks like, because if you meet it again, you can deal with it much easier. But this comes with risk. This is complex, this immune system, and it comes with risk, because if you think about it, to recognize foreign proteins with foreign molecules on bugs as foreign and dangerous, we also need to have this system evolve to recognize our own body and our own proteins as ourselves. And when this fails, as it does in about 7 to 9% of people in their lifetime, this is an autoimmune disease. So quite a few forms of vasculitis are in fact autoimmune diseases, and they result from our immune system not correctly recognizing our own proteins as harmless. In other words, there's a misdirected immune response in the body that leads to these inflammation of blood vessels. And the top two panels are these things called ANCAs, which are just antibodies that target neutrophil fighters and make them active and cause havoc. The bottom two panels, one's are CT scans, one's a cross-section of some quite badly diseased lungs, but I'm pleased to say this person made a full recovery. But if the inflammation goes on for a long time, you can get scarring or even some tissue destruction. And this is a front-on view of someone's nose. So there's little arrows where the nasal cavity is. And it's hard to see for sure, but the arrows point to where there's been some early bony destruction. So the immune system has to manage quite a few things. Clearly, it has to manage infectious agents, bugs, and an active response in the middle column there results in protection. If you have low or no response, there's a risk of more severe infection or the infection coming back. Similarly, sometimes our own cells can go rogue and the immune system can be quite good at picking this up. So an active response to funny looking cells that have gone wrong can lead to prevention of cancer or stopping that at an early stage. We made a problem for the immune system when we invented transplantation, because if you have an organ transplant, you want a low or no response. Otherwise, you risk getting rejection of the foreign graft. But perhaps more commonly, when we meet pollens or other innocuous, foreign but innocuous and non-threatening things, we need to have no response to it. Otherwise, we get allergy. This all leads to what I think for vasculitis is probably the most important concept, that if you respond to yourself actively, you get autoimmunity, and this can lead to vasculitis. What we need to do, and what most people have, is what we call self-tolerance. In other words, we don't recognize ourselves as foreign. So what are the causes of vasculitis? The majority of cases aren't known. I should say in the vast majority of people, there is some small genetic contribution, which we're starting to understand. These diseases don't tend, by and large, to run in families. So they're rare conditions, so the chances go up a little bit, but it is certainly not certain, and in fact, far from certain, in fact, very unlikely that if you have vasculitis, your son or daughter will also have it. There are some types that are more common with aging, which suggests that over time, the immune system has some slowly going wrong until tolerance is lost and one develops vasculitis. And these environmental triggers have attracted a lot of interest over the years and a lot of research. Many vasculitis, forms of vasculitis, probably have some sort of infectious trigger. There's a lot of discussion, debate about that over time. And strangely, we might learn more about that over time with the focus on COVID. Some drugs and medications, cocaine is a good example, that can cause vasculitis, and some medications that generally doctors know about have a low chance but can cause vasculitis. And lastly, working with silica dust is pretty well established to be a risk factor for vasculitis. Some forms may be more common in rural settings, but remember, these are rare diseases, so we're talking about a small excess risk. I wouldn't move from your bucolic rural existence to the city just because you were worried about getting vasculitis or making your vasculitis worse. There is little evidence for diet as a major cause, but we do wonder, like we do for almost any disease now, whether these trillions of bugs in our gut make some sort of difference in terms of either risk or trigger. I think it's a watch this space. We don't understand it particularly well at the moment, but it's something that may emerge in the future. Vasculitis affects different parts of the body, and you don't need to remember this diagram, and nor will there be a test on it. It's there really to show that in theory, vasculitis can affect almost any part of the body. Because it is often a systemic disease, in other words, a bodily disease, symptoms such as tiredness and fever are common. And tiredness is a really important symptom that tends to persist even when the vasculitis is inactive. It's often under-recognized by us doctors, but very commonly experienced by patients. Different types of vasculitis tend to affect different organs and tissues, and that's what this diagram is there for. You don't need to worry about the equals and the greater thans and the very much greater thans. It's just to show that even within the type of vasculitis I work most in, which is ANCA-associated vasculitis, the three different types can have quite different patterns of what they commonly affect. We don't understand that very well yet, except to say the body parts that are affected, in other words, the tissues or organs that are affected, tend to be the ones where the inflamed blood vessels are. So the small blood vessels in the skin causing trouble, you tend to get skin involvement. Small blood vessels in the lung, one tends to get lung involvement. So it tends to, the organ or tissue that's involved tends to be where the inflamed blood vessels are. And early on, this is the kidney here, and these little round things are the tiny little filters that I talked about, the glomeruli. Early on in acute inflammation, you tend to get signs that things are not quite right. So the one labeled G there is a normal looking tiny little ball of blood vessels in a filter under the microscope. The one labeled N with that orangey pink stuff shows early inflammation. If it gets worse and more severe, you can see the middle picture, although it's a different stain, the glomerular tuft, or the major part of the glomerulus, is collapsing around a ring of inflammatory cells. And if this continues on for too long, you can get scarring. So this is a lower power, but you can see this used to be a filter, but now it's not doing much work at all. These are pretty normal looking tubes, but here's some tubes that have been damaged and scarred by vasculitis. So the aim of our treatment is to switch off inflammation and turn back the clock as much as we can. We'd like to have direct things that protected and caused healing directly, but the way we try and get healing to happen is to prevent inflammation. The inflammation is too severe or goes on too much, one tends to get scarring and, unfortunately, at times, loss of function of the relevant tissue or organ. So this is, again, ANCA-associated vasculitis, but broadly speaking, many of the principles are similar for other forms of vasculitis. There's an induction phase of treatment that lasts for 3 to 6 months, followed by a switch to a lesser intensity of maintenance of treatment. And then most people with vasculitis do require some sort of long-term follow-up. So the aim of this is to turn active and quite severe disease, often in ANCA-associated vasculitis, so there are some people who don't need this intense induction, to what we call remission on medication, so on drug, on medication remission, and then to come off the medication over time. And when you come off can be very tricky for the doctor, for the patient, and it's often not clear and requires a fair bit of discussion. We hope people don't relapse, but sometimes the disease relapses and you need intensification of therapy again. There's not many people, but some people unfortunately have refractory disease, which is difficult to treat and requires a lot of thought and alternative treatments. Many forms of vasculitis are treated with prednisolone or prednisone or corticosteroids or glucocorticoids. Call it what you will, they're very similar. And they often start off sometimes intravenously, but often at quite a high dose orally, and this tapering down over time, hopefully to very low dose or nothing, is common. But vasculitis sometimes or often, depending on the type, requires another medication, which can be more intensive, or it can be later on, to spare people from the long-term effects of glucocorticoids. And my rheumatology colleagues call that a steroid-sparing agent. So the treatments, some types of vasculitis are self-limiting. In other words, they go away themselves. They don't require specific treatment other than supportive management. But many do require immunosuppression, as I showed in the last slide. And this immunosuppression can be quite effective. But if you think back to that table I showed you of what the immune system has to do, all these treatments can affect the good arm of the immune system as well as the arm that's malfunctioning. And therefore, they can, in some people, make you more likely to get infections. Furthermore, medications can have other side effects, and particularly the example I wanted to highlight to you, many of which, unfortunately, you may have experienced yourself, is the effects of glucocorticoids or prednisolone, the metabolic effects, perhaps on bone, on glucose, on blood pressure. So to protect your body from these sorts of things when you're on immunosuppression, doctors will often prescribe and recommend other medications to protect the body from effects of immunosuppression. For example, vitamin D and calcium, ensuring you get enough of both of those to limit the effects of prednisolone on bone. There are a number of other ways in which the body can be protected. 2 or 3 times a week, antibiotics, a particular antibiotic is often a common other form of treatment that limits the effects, the negative effects of this immunosuppression. Then there's supportive treatment for injured tissues. So remember, the blood vessels that supply the tissues are inflamed, but the tissues themselves can get injured. And an example here is in kidney involvement. Often blood pressure can go up, requiring temporary or in many cases permanent blood pressure treatment to protect the kidneys themselves, as well as the other parts of the body that can be affected by high blood pressure. We're going to hear from Mr. Mead about diet and exercise, and I would recommend that. And he's much more expert than I, and he's going to talk about that in more detail. And lastly, but not leastly, psychological support, whether it's your significant others and loved ones understanding you and helping you, or whether it's a healthy and sensible relationship with your clinicians. Some people need more than that. And I must say that many rare diseases were a bit underdone in being able to, the health system, and be able to give adequate psychological support. Where do we need to progress? We need better treatments. We need better use of current treatments. And recently in ANCA-associated vasculitis, there was a trial called PIXI-VAS, which trialed two things, and I want to focus on the major outcome, which was we reduced the amount of prednisolone in the acute phase of this condition by 45%. In other words, we nearly halved it. And that's come out in the last couple of years, and that's a major treatment advance. Nothing new in terms of what we're using, just we're using it better. I would like to see, and we would like to see, better availability of some of the current treatments, and this is because of funding or other issues. We'd like to see new or more targeted treatments, some of which are coming through the pipeline at the moment, and also making sure these protective treatments to protect people from the effects of the disease or the treatments are being used more consistently. Better understanding of the causes is likely to lead to new therapies, more education and support. I'm all for people with a condition, particularly if it's going to be a chronic condition or a long-standing condition, understand what's going on. Knowledge is usually power in this situation. At ANZVASC, we've started a program now slowly, and we're winding it up over time. I hope to help educate and train clinicians via a number of mechanisms, including understanding better the patient experience. Blood tests and talking to patients are important, but also understanding how they feel over time with a chronic illness is really important. And lastly, with any disease, particularly with a long-standing disease, awareness and advocacy is important. And lastly and quickly, and this is perhaps a bit presumptuous of me, some things you might have think about, and you've probably thought about these already, so I'll run through them quickly. Being positive and trying not to let the conditions define who you are. That's a truism for almost any disease. You're just a person who happens to have vasculitis, not the other way around. Try and understand the conditions and the treatment you're taking. Questions are good. The internet can be useful, but be careful what you use. Vasculitis Foundation website is very good, as is, and we're developing further the ANZVASC website over time. Interacting with other patients groups can be beneficial. If you try alternative or complementary medicines, please let your treating doctor know. Almost all doctors would rather hear, we know lots of people do, would rather hear, so we can give any other necessary advice that's necessary. Not every symptom is your disease. Tiredness is a good example. It doesn't always show active disease. There are lots of reasons: disease-related, medication-related, psychological, lifestyle, and just general living why people can be tired. Healthy habits, sensible diet. Please don't smoke. Try and maintain, it's easier said than done, a healthy weight range, and take graded exercise. Consider helping with research efforts, and again, a little cheeky, consider joining ANZVASC as an associate member. We'd love to have you. That's all from me from now, but I'm happy to take any questions later on. Thanks.
Thank you very much, Richard, for a wonderful presentation. So next we're going to move on to Associate Professor Karuna Keat. He's a clinical immunologist and allergist who works in Campbelltown in New South Wales. He looks after patients with all forms of vasculitis, and he's going to talk to us today about how to interpret your test results.
Specialists may have done some inflammatory markers. As doctors, will talk about inflammatory markers, specifically referring to two main tests: the ESR, which is a erythrocyte sedimentation rate, which is a non-specific marker of inflammation. It's probably the oldest test around in terms of looking for inflammation. It doesn't tell you exactly what's going on. It suggests something's going on. I use it in certain all the vasculitis patients I see, clinics I see, but it's probably more prominent in the large vessel vasculitis, such as giant cell arteritis. ESR can be high, but it needs to be taken into account age and sex as well. The older you are, the higher the ESR, as well as being female sex. If you're anemic or having a low blood count, the ESR can be high. It's a pretty simple test. Basically, they take your blood, they put it in a plasma tube and spin it down and see how long the red cells take to settle down. As you can see in the gloved picture pointing to what the ESR is. It's measured in millimeters per hour. So the other inflammatory marker is the CRP. As you can see on the graph on the right, the CRP stands for C-reactive protein. It's a protein which gives you, again, a non-specific marker of inflammation, but it could suggest infection or inflammation or vasculitis or other causes. But the advantage of the CRP, as I tell my students, it's not just a blood test. It actually is it has a significant role in the immune system in fighting bacteria by coating bacteria and activating their immune system. However, in the clinic or in the doctor's rooms, they may be doing the CRP to suggest inflammation. CRP is used usually in conjunction with ESR because it's quicker, it responds quicker to inflammation, it rises about 800% fold potentially after bacterial stimulus, as you can see on the graph here on the right. It comes down quicker, so it's easier to monitor over a shorter period of time of days or so, compared to the ESR, which may take longer. And I suppose you tend to do this CRP more frequently than the ESR. So these are examples of the inflammatory markers, the blood tests your doctor would be performing on a regular basis, perhaps every 3 months or so when they monitor you, or when you become acutely unwell. It may suggest a problem. The other tests, which may be considered acute phase responses or inflammatory markers, are sometimes ferritin and the albumin. Sometimes they'll do the ferritin. Ferritin suggests iron stores, how much iron you have. However, when you're acutely unwell, it can be elevated significantly. Albumin is a protein in the blood which can be reduced in kidney disease, particularly kidney disease and forms of vasculitis affecting the kidney. But it's also a marker of an acute phase response, which means that when you're acutely unwell, it'll go down quite significantly. It's a negative acute phase response. So 3/4 of the patient in ICU who are acutely unwell for other reasons will have a low albumin level for multiple reasons, but one of those reasons is because they're unwell. So they're the inflammatory markers. Richard's already shown you some pictures of the ANCA. With the ANCA-associated vasculitis, it's helped define and diagnosed small vessel vasculitis over the last 30 years, since it was initially written about by David Davies in the early 80s. So the ANCA test is anti-neutrophil cytoplasmic antibodies. These are antibodies against neutrophils within your bloodstream. Neutrophils are white blood cells which are responsible for inflammation and also fighting infection. Originally, the test was performed using immunofluorescence, which means they get someone's donated neutrophils. For example, when I was a registrar at Westmead, I was the neutrophil donor, forcibly. So what happened would be that you get the neutrophils encoded in a glass slide. They get your blood, spin it down, get the serum, which is the component which contains the antibodies, put it onto someone else on the slide with the neutrophils and see if it binds, essentially. They'll do a couple other processes and then they'll put it under a light microscope, an immunofluorescence microscope, and you get a particular pattern of staining. For example, the P ANCA, which is the one on the left, is associated with perinuclear ANCA, which again is essentially associated with a specific protein called a myeloperoxidase, or an antibody to myeloperoxidase. Then there's C ANCA, which is confusing because people still use the term cytoplasmic, but it refers to the classical pattern of an anti-neutrophil cytoplasmic antibody. You get this granular staining in the cytoplasm. That's the tissue around the nucleus of the cell, but within the cell itself. And that's generally associated with PR-free or proteinase-free antibodies. So when a doctor orders the ANCA, usually they'll do two methods. The laboratory will perform two tests, the immunofluorescence, which is a picture on the microscope, and they'll perform another test, which is the equivalent of an ELISA test, a more specific antibody test for MPO and PR-free. There are other proteins or antigens which can be tested for, but have not shown clinical significance. So it's important to understand the MPO and PR-free because that helps make the diagnosis of either microscopic polyangiitis or eosinophilic granulomatous polyangiitis or granulomatous polyangiitis. However, people are starting to use the MPO and PR-free to identify the disease associations. With people with PR3, they tend to get more organ system involvement rather than just one particular system. They also tend to respond better to certain forms of treatment, such as rituximab, compared to those with MPO necessarily. Your doctors will generally be performing the specific MPO or PR3 depending on your result every 3 months or so, usually. Some doctors use it to determine if there's a chance of relapse. It's not clear, but there are associations with relapse, but it's not always consistent. So if you've been diagnosed with a PR3 ANCA-associated vasculitis, you've had treatment, and the PR3 has disappeared from your blood test, they can't detect it anymore. If it comes back up, it may suggest there's a chance of relapse, but it's not always consistent. So the doctor will probably use the combination of other factors, other tests available to help determine if they need to escalate treatment for you. The MPO and PR3 are reasonably specific. That means it alludes to a strong suspicion of vasculitis. However, that's not 100%, and it should only raise the possibility of vasculitis if you've got other symptoms, because sometimes you get low levels, which may be not all that relevant. The other thing is, if you've got an ANCA positive result, it makes it easier to access PBS or pharmaceutical benefit schemes, medications such as rituximab, as opposed if you don't. And that's one of the criteria for the ANCA-associated vasculitis. You have to have a positive ANCA and an organ-threatening, life-threatening organ involved. So we'll talk about other blood tests which your doctor would routinely do every 3 months or so when they're monitoring you. They may do the electrolytes, which checks the salts in your blood, the urea to see if you're a bit dry, and as part of the creatinine to determine if your kidney function's going off. The liver functions, people can have vasculitis in the liver, but less so. However, I routinely perform the liver function tests such as ALP, GGT, AST, and ALT to determine any potential side effects of the medications we're providing. Because medications can cause adverse side effects, and it's important to monitor those side effects and whether we need to change medications depending on that. The blood count can be a marker of disease activity, such as the full blood count, such as the amount of white cells you have, the amount of red blood cells you have, which is marked by the hemoglobin. And the platelets are used as a marker also in other conditions, especially it suggests inflammation. But it's very useful in a condition called giant cell arteritis or temporal arteritis in terms of assisting in making a diagnosis or suggesting a flare. But again, it's non-specific. So these tests on this table we generally use for monitoring side effects of medications. And if you were to start to relapse, it may suggest you're relapsing. Some doctors will do B cell subsets. I'm not sure if you've heard of B cell subsets. Generally those who've been on rituximab. There's a school of thought which suggests that if rituximab essentially lowers your B cells, it's an antibody which lowers your B cells eventually. And if your B cells start coming back in numbers, they may think about giving you more rituximab, as it may suggest there's a chance of a relapse. It's not necessarily borne out, but I do B cell subsets on patients who have been on rituximab to give me a bit more information. Your doctors will also consider at some point in time, especially if you've had multiple courses of rituximab, that is more than 3 to 4, or if you've been on medications which are immunosuppressants for a period of time, especially if you're getting recurrent infections, IgG, IgA, and M levels, predominantly the IgG levels, as sometimes your antibody levels you produced, ironically, even though you may have ANCA-associated vasculitis, you have low antibody levels and a predisposed infection. because of the immunosuppressed state and the medications you've had. So we come to biopsies. Biopsies are performed, as I suggested, the most commonly performed for ANCA-associated vasculitis is probably the kidney biopsy, especially in certain units such as Richard's unit, because they're nephrologists. Kidney biopsies are performed to confirm the vasculitis is in the kidneys, because it changes the amount of treatment we need to perform. It also needs to determine the extent of disease, as it depends on how much kidneys have been, how many of those glomeruli that Richard showed have been damaged or scarred already, and also to exclude other diseases. And that's important. Just because you have ANCA-associated vasculitis doesn't mean that other diseases could be contributing to the kidney disease. That's usually performed using histopathology, again, immunofluorescence, and this is a picture on the right here of a condition called Goodpasture syndrome or anti-GBM disease. This is a classic crescent, as Richard's alluded to, where there's infiltrates of inflammatory cells into the space for the filtration of the kidneys and damaging the filtering system. And sometimes I'll do electron microscopy as well. If your doctor suspected that you have temporal arteritis or giant cell arteritis, they'll strongly consider performing a temporal artery biopsy. So you actually donate your arteries to the surgeon, to the lab, and cut it out, and they use it to help confirm diagnosis of temporal arteritis. This is important because the treatment we usually give are quite toxic, potentially toxic immunosuppressants, and how long to treat for is important, because in temporal arteritis, potentially people can go blind and have other manifestations such as strokes and non-specific inflammation. The picture on your right here with the figure shows a normal looking temporal artery. The arteries have they have the inside a tube, the lumen. They have three layers: the intima, the more muscular layer, which is the muscular, and the adventitia. The media, the intima, the media, and adventitia. As you can see here, in a biopsy of someone who has vasculitis, there's inflammation, there's more cells getting into the media, there's damage, there's narrowing of the lumen, which is the opening of the tube itself, and there's damage to there's intimal hyperplasia, there's infiltration and damage to the inside layer of the vessel, blood vessel. In giant cell arteritis, the reason I call it giant cell arteritis, you get these inflammatory cells forming these giant cells here, demonstrated by that arrow there and there and there. That helps because, again, if you make the diagnosis, now you can access a medication called tocilizumab, which allows you to reduce the amount of steroids you need at a quicker pace and reduce the steroid burden and reduce the steroid side effects. However, especially if you don't have access to a PET scan, the PBS will allow access to a PET scan or showing giant cell arteritis for people to access this drug. But temporal artery biopsies are still routinely performed. The easiest part of the body to biopsy is probably the skin. People with ANCA-associated vasculitis can get skin manifestations and do get skin manifestations. However, there are other forms of vasculitis, such as IgA vasculitis or Henoch-Schönlein purpura, as demonstrated in the picture here. These lesions which are palpable, that means you can feel it, and they don't blanch. You perform a skin biopsy, and you can do normal histopathology, which looks for, again, changes in the blood vessel, infiltrate of neutrophils in this case, or other inflammatory cells, and narrowing the lumen of the blood vessel and causing damage. You can perform immunofluorescent testing, again, similar to the ANCA testing, but looking for a specific staining of an IgA in the blood vessels in the skin, which demonstrates IgA vasculitis or Henoch-Schönlein-Purpura. So the skin biopsies allow easy access, again, are helpful to help diagnosis, and you can help diagnose vasculitis in the skin, and I've diagnosed ANCA-associated vasculitis in the skin on a combination of blood tests and also the histopathology. Sorry. So it helps, and it also helps determine treatment options. As I deal with patients with muscular and neurological problems as well, we perform muscle and nerve biopsies in certain circumstances if you're feeling muscle pain or weakness. It's interesting to note that sometimes it's easier to biopsy certain organs because it's less likely to cause damage to other organs and it's easier to access. Muscle biopsies can be performed, demonstrating, again, vasculitis, as in picture A on top, in a muscle. A cohort of French patients with ANCA-associated vasculitis who had just muscle pain and weakness, about 57% of them, that is on a blind biopsy, if they had pain, muscle pain or weakness, their doctors decided to do a muscle biopsy, and 57% of them demonstrated vasculitis in the muscles. And so muscle aches and pains can actually be a manifestation of vasculitis. The other organ which can be, or part of the organ which can be biopsy, is the nerve. Certain ANCA-associated vasculitis, such as Churg-Strauss or EGPA, may manifest as mononeuritis multiplex, whereby you get pins and needles and numbness in different nerves in parts of your arms and legs, other parts of your body, and weakness developing. If you can't access, if there's no renal kidney involvement and there's no skin involvement, you may have to do a sural nerve biopsy, whereby a part of your sural nerve is donated to the lab, and essentially that involves the advantage of the sural nerve. It's only responsible for sensation. It's not responsible for any strength. You'll have a little bit patch of numbness. It's a commonly performed procedure, and it may show, again, inflammation in the blood vessels within the nerve itself and helping make a diagnosis. Why do this? All these things, all these biopsies, the biopsies are useful to confirm the diagnosis. The ANCA blood tests help confirm that as well, but there's always a possibility that it's not 100% definitive. So you have to have the biopsy results to help confirm the diagnosis, because we're going to have to escalate or provide quite potentially toxic medications to try and induce remission. So I'll open for questions and comments at the end, unless there's any burning questions or comments, Jessica.
Chance to get a cup of tea. Next up, we've got Dr. Damon Langooth, who is an immunologist in Queensland, and he's going to talk to us about quite a hot topic at the moment, so infections and immunisations. Thanks, Damon. Oh, you're on mute.
Yeah. Okay. So thanks for asking me to talk, and also thanks for everyone for coming on a Saturday. So my talk is about infection and vaccination and vasculitis, and I have left COVID till last, so you might listen to the first things first. I do realise that's a more important and more exciting issue at the present time. So infection in vasculitis can be summed up in one word: corticosteroids or steroids, or prednisone or prednisolone or dexamethasone. And so what we've done over the last 30 years is swap risk from disease to risk from treatment. Now, you might think, well, that's not much of a change, but it's a huge change. Instead of thinking about patients who might succumb and die from their illness, we now think about patients who get trouble from the treatment that we give, and we try and minimise that. So our big focus, or a big focus, is certainly over the last 20 years, which I've been a doctor involved in vasculitis, is that, yes, we've had problems with control of disease, but now we can help people survive. We need to make sure they don't suffer from the consequences of treatment. And that's been a very big focus, because we know from lots of studies done in the 80s, 90s and 2000s that the treatment we give helps people survive. But, you know, as a patient, I'm sure you would agree that just surviving an illness, well, that's really important. But then it becomes, well, how can I get back to a normal life? And, you know, as a doctor, I always say, my job as a doctor isn't done unless I can think you're a person who happens to have a disease rather than a diseased person who spends their time being diseased. So corticosteroids, or we often shorten that to steroids, some names are there that you can see. So prednisolone, prednisone, methylprednisolone and dexamethasone. Now, to give you an idea, 10 milligrams or equivalent of prednisolone doubles the risk of bacterial infection. Now that starts at day 1. So your risk in lots of studies shows that the minute you're on steroids, your risk of bacterial infection goes up. It, of course, depends. If you were going to die of a disease the next day, that's a perfectly reasonable risk to accept. And once again, this introduces a concept of risk versus benefit. And that, because it's quite easy when you're terribly unwell, but it's very difficult when you're in a maintenance therapy. So the single greatest risk is during induction. So in other words, at the start of your course of vasculitis, and pretty much in all forms of vasculitis, we still use somewhat large doses of steroids, if not large each day, large equivalent over time. And we know that long-term treatment, and I count that at 3 months really, every 1 milligram you receive of steroids increases your risk of bacterial infection. As Richard alluded to before, risk doesn't equal getting stuff, it's your chance of getting bad things happening. And that the more comorbidities, in other words, the other diseases that you have already, some of those, of course, in a relapsing disease might have been caused by the disease treatment we've given you before. But the more that you have means the more that you are at risk. And thus our concentration on trying to reduce these things long term. Old studies. So back in the 1980s, when the treatment for ANCA-associated was essentially cyclophosphamide and steroids, we noted that a certain fungus called Pneumocystis jirovecii, or it used to be called Pneumocystis carinii, caused a particular problem. But unfortunately, medically, I think the takeaway message was that cyclophosphamide was bad, when in fact the greatest risk for that disease was steroids. And we now know that in vasculitis and in other conditions where you receive more than 3 months of prednisolone or equivalents at 20 to 25 milligrams and above, that's a risk for getting this particular infection. Now, this infection is what we call ubiquitous, meaning everywhere. So this little organism lives in your house, in airways, lives at work and at home, and everywhere you go on holiday, in the soil, pretty much everywhere. And pretty much most people would breathe this in every day. So the vast majority of people do not get this infection. But the biggest risk, as I said, is steroids, and then cyclophosphamide, and then what we call structural lung disease. So if you have lung damage from vasculitis, typically an ANCA or PR3 vasculitis, that you are much greater risk of developing this infection. Now, luckily, the vast majority of this is preventable using medications called Bactrim or Septrin, which is a combination of 2 antibiotics called trimethoprim and sulfamethoxazole. Now, we actually have the HIV epidemic to thank for that, because that's where most of our knowledge of this infection, which unfortunately infected people with HIV, so we have a huge amount of information about how to treat that. And it's a far less common problem now that we, most of the time, standardly use this medication to prevent these infections. So talking about infection risk, cyclophosphamide into the 90s still, and perhaps into the 2000s, was still commonly used as a maintenance agent for certainly ANCA-vasculitis. Nowadays, we would think, thank goodness, this is gone. We saw fungal infections increase, bacterial infections increase, viral infections increase. Cyclophosphamide I allude to as a sort of shotgun approach. We still use it. It still has benefit. It's still, in some patients, not that risky, but as an approach, it's not targeted. And then we saw, as azathioprine was introduced as a maintenance medication, then perhaps methotrexate and mycophenolate, we saw infections fall. So in other words, cyclophosphamide is much more immunosuppressive than other agents. And through the 80s and 90s, there were many studies that concluded that other drugs could be used instead of cyclophosphamide, either as a maintenance, i.e. long-term agent, or in some individual and perhaps somewhat limited forms of vasculitis, methotrexate and mycophenolate could be used. But with the introduction of rituximab, whilst there was a perhaps benefit, compared to cyclophosphamide, there was no further change. So people really wondered, why was this? And once again, we return to our old friend and enemy, a true frenemy. Prednisone, dexamethasone, prednisolone, all help people survive vasculitis at the start. But the long-term effects are legion, and they are the greatest cause of the increased risk of infection. So now we have some studies, and a study alluded to by, I think, Richard before, called ANZVASC, which looked at lower doses of steroids. Now, it wasn't designed to show a reduced risk of infection, but the lower dose of steroids only just showed that there was a slightly reduced risk of infection. And so clearly new approaches are needed to use less steroids. The trouble is that some patients, to control their acute disease, will need higher doses of steroid. So that we need to have an approach that says, okay, what's the best approach for the vast majority of people? And then if you don't fit that approach, well, that's where the acceptance of high dose steroids is worthwhile. And there are many new approaches coming around which are trying to spare steroid dose. One of these is a medication that blocks C5a receptor called avacopan, and it has just received TGA approval. And I might just say it's just, not just in time, but just because many were not agreeing with the study. And there were a lot of study designs that perhaps weren't the best and did not show the potential benefit of this medication. Potentially, and I say potentially, medications like this have the potential to spare patients from corticosteroids. And the greatest risk reduction is in diseases that are relapsing. So that ANCA positive, particularly C-ANCA positive or PR3 or GPA vasculitis, is by nature, unfortunately, a relapsing disorder. So that some of my patients certainly have had 4 or 5 relapses during their time, often many years before meeting me. And I can't say that I particularly have changed that much because I don't have enough data to say that. But I know that these patients will receive large doses of steroids in the induction of their vasculitis, and that every dose of steroid increases the risk of infection, let alone the myriad other side effects of prednisone. So we all want other drugs to take the place of the steroids, and that with avacopan and potentially new agents, we might get there eventually. There are some drug-specific side effects which lead to increased risk of vasculitis. So a drug called azathioprine, or the brand name for that is Imuran, particularly increases the risk for the herpes simplex viruses, which are the cold sore virus, genital herpes virus, and as well as varicella zoster. So that's the chickenpox virus, which manifests as shingles. Mycophenolate, drug less used in vasculitis, but particularly keen on in Queensland, where azathioprine has another effect of enhancing skin cancers. Mycophenolate, when given with corticosteroids, really increases your risk of varicella. So in other words, the recurrence of shingles. Now, shingles has an incredible rate of comorbidity. So in other words, a very great chance of causing severe pain, loss of quality of life, and also a decent chance of causing chronic pain, which is difficult to control. Now, so that clearly may well influence your course of disease. So in other words, if you have an vasculitis, but we've treated it successfully, but you've suffered severe pain due to another disease which we've induced, most patients would not necessarily count themselves as being better off. They're alive, but being alive with lots of problems is not necessarily that great. With rituximab, we have an increase of bacterial pneumonia. We have a unknown but definite risk of pneumocystis, that fungal infection I was talking about. And importantly, we have a risk of hepatitis B reactivation. So hepatitis B is rare in Australia, but it's endemic in Southeast Asia. So this is a infection acquired usually as a child, much more likely if you're a man than a woman, so about 9 times more. The reverse of many vasculitides. Unfortunately, most vasculitides are ecumenical. They don't really care who you are. And so they give an even spread of disease across men and women. But hepatitis B reactivation is critical. And so that's why we check hepatitis B presence before we give you rituximab. If obviously you're immune to hepatitis B because you've been vaccinated, that becomes less important. But it's a very important thing to look for, because death from hepatitis B reactivation has been recorded, largely in Southeast Asian countries where the virus is much more amenable. That's because of a genetic risk of people from Southeast Asia, not from anything else. Now, tuberculosis. Once upon a time, not long time ago, as in 50 years ago, tuberculosis in Australia was a serious risk. But it still remains a serious risk in many, many other countries. And so treatment for vasculitis can increase the risk for tuberculosis. Most of our treatments don't actually do that much, but it's absolutely important that we consider that, especially in people who've come from other countries or lived there for greater than 6 months. So particularly the Soviet Union, some Eastern European countries, and some African countries. So now we get on to the interesting, perhaps for most part of my talk, vaccination. So the concept of vaccination is that we prevent disease. We don't reduce it to zero. We can't do that, and we shouldn't pretend that that's what we're doing. Though in some vaccinations, they have been so successful that we essentially eradicated disease, such as smallpox. I might remind you that smallpox killed more than 500 million people in 30 years prior to vaccination. And that vaccination came around in the 60s and in Australia. Largely we're in vaccination now. We've got rid of most of the ones that cause us problems all of the time, and we're introduced in reducing infection risk. So the critical thing here is, I think, prior to treatment with treatment for vasculitis, obviously no one knows when they're going to get vasculitis. There's an importance on keeping up with the standard age-related vaccine schedule, because that puts you at a lower risk of developing disease after we treat you with drugs that potentially increase your risk of disease. And obviously the biggest risk is at the start of treatment. The highest dose of steroids you're going to get is at the start of treatment, and other agents. And unfortunately, we can't wait to treat that in the vast majority of cases for you to be vaccinated. In other words, if you're at risk of going blind from temporal arteritis, or having bleeding in your lung, or kidney damage, or nerve damage from ANCA-associated, we can't kind of say, oh, just wait a bit, we'll need to vaccinate you first and we'll see how you go. Obviously, we need to then treat you, and then we don't have a chance to vaccinate you, largely because those treatments will essentially block completely the vaccine response. The initial risk is in reactivation of what we call endogenous viruses. These are viruses we generally acquire as teenagers, young children, or adults. So viruses called herpes simplex 1 and 2, they're the viruses I've said before that cause cold sores and genital herpes, and acquired as chickenpox, but then recurrent as shingles. Now, you might think that genital herpes is a rare condition and that only occurs in people who have been promiscuous, but in fact, you only had to have sex once to get HSV2. It's not uncommon. It's far more common than people think. It's not a reflection on your personal standards. And much like HSV1, which causes cold sores, it's very easy to catch. And these two viruses are present in about 90% by the chance we always die, And chickenpox is the virus, the varicella virus, is present in about 70–80% of people when we die, if we look at autopsy series of all people who've died of any cause. Now, we know that vaccines can be effectively blocked by some medications. So there's very good data on rituximab or Mabthera that effectively reduces the seasonal influenza vaccine to around 3%. So in other words, it's not totally useless, but it's not very useful. The other thing is that we don't have an idea on how these medications suppress vaccine responses. So in other words, if you receive 1 dose of rituximab or 2, we don't really know how long that suppression lasts, and it's likely to be individual. Some patients may well remain suppressed for a long time, i.e. more than 2 years. Many other medications also suppress vaccination responses, and I've listed them there. There are some methotrexate guidelines from the Australian College of Rheumatology and the American College of Rheumatology that suggest that if you can, you're best off ceasing methotrexate for the week that you receive the flu vaccine and the week that you receive the COVID vaccine. And this may well apply to other vaccines as well, though we haven't had any guidelines on that. One thing with varicella or shingles is that at present we have a live virus vaccine in Australia, which essentially counts out all people who are on steroids at doses above 10 milligrams and any other drug. Luckily, from July 2021, only 2 months away, we'll have an inactivated vaccine available. Unfortunately, this is not going to be funded as yet. It will come in almost certainly to funding in the standard vaccine schedule, but it is at least available. The other thing that people don't think about is pneumonia. Pneumonia is common as a cause of steroids and a consequence of other immune infections. There are 2 types of vaccine, the Pneumovax 23 and the conjugated Prevnar. Now, Prevnar is much more effective. In other words, about 50% more chance of suppressing pneumonia from the pneumococcal bacteria. The timing needs to be discussed with your doctor. Some are funded and some is not. Now, we don't have many people with vasculitis who are under 16, but it's been on the childhood schedule since 2005. So those people will remain have a useful vaccination lifelong. Influenza, it's unique as it is sharing across species properties. In other words, new viruses are created yearly. Its recombination is very different from what you've heard about the mutants in COVID vaccine. The trouble is we need to have revaccination each year. New vaccinations, however, are being developed, and they may give long-lasting immunity because they're a different type of vaccine. Whilst I often recommend that repeat vaccination might be effective, so in other words, you have an initial vaccine at the start of the flu season and another one later in the season, we don't really know whether that's effective, but it's often given by many physicians. Now, for the last few minutes, COVID-19. Unfortunately, the risks for serious disease are age, steroids greater than 10 milligrams, diabetes, and rituximab, and pretty much all suppressive agents in the immune system. Now, luckily, we have the COVID-19 Global Rheumatology Alliance. I can say that it was started by a friend and colleague of mine in Brisbane who saw the need for us to study patients such as listening today, but all patients who have rheumatologic, immunologic diseases. This has led to studies that have shown rituximab increases the risk if you develop COVID-19. Now, the trouble with rituximab is not that it causes long-lasting B cell suppression. That's why you might get much better control of your disease, but that it kills off the good B cells as well as the bad ones. Now, there is no difference in the good and the bad from the point of the immune system. The only point of the good and the bad is how it has effects on our bodies itself. We know that even when you reconstitute your B cells at 6 to 12 to sometimes 14 months after rituximab, that you may not still make antibodies. And this effects on vaccination is largely unknown. We don't know about the timing of vaccination. We don't know if it's worthwhile. We perhaps might make use of the present vaccine schedule, but this is challenging. So it might be that the vaccination schedules that are shorter, in other words, at time 0 and 3 weeks, might at the end of, say, when your rituximab is working, might be better. But honestly, we don't know. And in fact, complicating today or yesterday, there was a study showing that delaying the Pfizer vaccine to 3 months gave a greater vaccine coverage. The trouble is that we live in a country which hasn't had much COVID disease, and so it becomes very difficult to decide for an individual patient what is the best course. So I put a few questions here. Should I have cyclophosphamide instead of rituximab because you're worried about a vaccine response? I personally think that the best approach is that you should have the best treatment to control your disease. Worrying about prevention of something is not as important as controlling a disease you already have. That's my personal philosophy, but I would think that was widely accepted across many doctors and many patients. Should I delay my next dose of rituximab for my COVID vaccine? Well, that's delaying something that has definite effect for something that we don't know. So in medicine, we tend to treat on what we know. We ask patients to understand that what we don't know, and then we share that information with them, and we ask them to make a shared decision. Should I change to other medications? Well, that's a giant unknown. So as a parting thought, since I've been a doctor and I started in 1996, the risks of infection and vasculitis have declined, and I won't say declined, I'd say declined significantly, though they remain a major issue, especially in those who have accrued damage over multiple years of multiple relapses. So I've looked after people who started their career in vasculitis, and I'm sorry to refer it as a career, but I essentially, unfortunately for them, think it is. And they started their vasculitis when I was a small child. So we don't know about them. Luckily, we've had little COVID in Australia, and even that in Victoria, who had to suffer a great deal from that disease. Compared to other countries like India, the risks are much lower. Now, the risk versus benefit of when you might have a vaccination, what treatment might change remains a challenge. I would encourage you to all to discuss this with your treating doctor. And please understand that the answers aren't atomic. The answers are changing, and that pretty much every day across the literature I'm talking about is that we have different answers. We have more information, but we don't have the right answer yet. Thank you.
Thank you very much, Damon, for a great presentation. Now, our last speaker today is Mr. Anthony Mead. Anthony is an advanced renal dietitian at Central Northern Adelaide Renal and Transplantation Service. He brings over 20 years of experience looking after people, in particular with kidney disease, with vasculitis, but also other inflammatory conditions. He's also an accredited sports dietitian on the side, working with elite sporting teams and athletes. So Anthony, thank you very much for joining us today, and we'll get you started.
Thanks, Jess. I'm assuming you can hear me, and I'm assuming you can see my
We can,
slides,
thank you.
That's good. Please tell me otherwise. Thank you for that introduction for a start, and thank you to the other speakers, definitely. Now, let's move on. So I've deliberately gone a bit light on from a slide point of view because I imagine there's going to be some questions, and I've allowed some time for that. But the other presentations have certainly led into this quite nicely. So my topic is about diet and exercise in chronic inflammatory disease, primarily vasculitis. And my experience as a renal dietitian certainly see this often enough, but we see it in all the different stages. So in terms of what I'm going to essentially talk about over the next few slides is sort of the three different phases, if you like, of having vasculitis. So the acute phase, which we've been hearing a lot about, and particularly the effects of the high dose steroids in particular and cyclophosphamide, the effects of that are often to increased appetite. You eat more, your weight can go up. The steroids also can increase blood sugar levels, and in people with diabetes make blood sugar control particularly difficult, but even increasing blood sugars in people who don't have diabetes. And as a result of just not feeling very well, physical activity certainly goes down, and people can become quite deconditioned. So in the short term, there's some interesting things to consider, because on one hand, we've got medications that are increasing appetite and pushing you to want to eat more, but there's other things at the same time which are potentially pulling in the other direction. And certainly the side effects of the steroids sometimes, and cyclophosphamide as well, in terms of things like maybe taste changes and even issues from a immunosuppression point of view, mouth ulcers and these sort of things that can affect how you might perceive food, chew, swallow, taste food, can all be challenges. So there will be some people who are eating really well, and that's the problem that we need to address. There are other people who might really struggle to eat well in that early phase of acute vasculitis. I'm going to talk to the nutrition side of these things in a minute. As was very nicely described just before, no one expects to get vasculitis. You're not planning on getting it. And I imagine most people on this session today are not in the acute phase of vasculitis, but might have been there in the past. But you're probably more likely to be familiar with the phase of remission, where the focus is more on reversing some of those side effects. So if weight has gone up, if sugars have gone up, for example, then it's then about trying to reverse that, bringing weight back down a bit, improving blood sugar levels, and hopefully feeling better and starting to get more physically active and get that conditioning back. By conditioning, it's really the strength and muscle mass that can suffer, and everybody needs that for general health, basically. But the risk, particularly as people get older, with falls and with balance and those sort of things, are certainly risks in other ways. So in terms of remission, we are talking about how to manage general health, basically. But there are times when this condition certainly progresses, and that may be to end organ damage like kidney disease, which is the area that I primarily work in. But that might also be the organ damage as a result of diabetes, for example, on vascular issues and all of the things that come with, say, diabetes or blood pressure, those sort of things as well. So we need to understand that there's individualized needs. Some of those things might need dietary restriction, but other times they might not. But also, again, it's almost coming back to a phase of feeling unwell again, and then that lack of physical activity and the deconditioning can come, and then we've got trouble again in terms of frailty and in some ways the risk of malnutrition. So we go from sort of phases of overnutrition risk to undernutrition risk and all of the things in between. So what can we do? Well, not rocket science at the end of the day. I'm not going to tell you anything that you may not already thought about or be familiar with, but diet and exercise are essentially two things that are things you can do and are things that are well within your control. Alongside, taking your medications and other things, these are things that only you can do. So if we're thinking about that acute phase where appetite can certainly go up or down, it's very much about getting in tune with it. If you know that appetite is going to go up, then you can be more aware of it. You can be more mindful in terms of what you eat, when you eat, understanding that craving and those thoughts that come with high-dose steroids sometimes can be avoided with distraction potentially, but just knowing that that's what it is might be able to make a mental shift to avoid just giving into that and going and eating more. And even eating more in a healthy way doesn't necessarily prevent that weight gain that we see with steroids. It is, in my experience, something that affects different people in different ways, but people who are prone to be overweight are probably more likely to suffer the effects of steroids in terms of weight gain than people maybe who've been a very healthy weight all their life or potentially on the underweight side as well. So it's about thinking about portion sizes. It's about thinking about when you eat. And, you know, mindfulness is a term that's used in a lot of areas these days, but particularly in terms of nutrition, because if you're aware of what those triggers are, then you're in a better position to be able to do something about it. It then comes down to choosing wisely. So if you know your appetite is really high, or the other way too, if appetite is poor and maybe eating is a bit of a challenge, it's the same but opposite strategy, if that makes sense, in that the quality is going to be important, maybe more so than quantity, and that may be nutrient-rich choices, so more in the way of you know, fruit, vegetables, etc., and rather than necessarily high energy nutrient poor choices. On the other hand, if weight is something that is going down and appetite is poor, then getting nutrient dense foods and energy dense foods at the same time is going to be an important strategy. So it's important to know and understand what's going on and certainly address it. It's one of those things that in the hospital setting where I look after people in exactly this phase, is sometimes we don't necessarily get the referral because people like our nursing staff or the doctors may not necessarily pick it up that there's any problems, but I will go and see people when they get diagnosed in this way to just give them a heads up that these symptoms might be apparent and that there is some strategies maybe to do. Because there's no point letting it go until someone's gained 10 or 15 kilos and then saying, right, now try and lose weight, if we could have done something about it earlier on. The other thing is even in a situation of feeling under the weather, let's say, or unwell or pretty knackered, keeping active is really important, but what we tend to see is people drop that off because they're feeling a bit tired or a bit worn out. And basically every little bit counts, even if it's short bursts multiple times during the day. It's not necessarily about having to try and run marathons or anything else, but we want to prevent that decline in muscle mass, that risk of frailty in particular, and that deconditioning that's sometimes really hard to get back from. And one thing that's really important as well is we know that this is not just about the, you know, the little old person that you might think of and you go, oh yes, they're old and frail. People who are overweight, people who are bigger people can have loss of muscle mass as well. And we talk about this term of sarcopenic obesity, where you can be overweight with low muscle mass and you still have potentially higher risks of falls and fractures and all of the other things that go with that as well. So we want to keep people active. It's a really important message, and even when it is hard. If we think about remission, then in very simple terms, nothing sexy about this message at all. It is about healthy eating. But, you know, we can say that. What does it actually mean? The reality is there's lots of different ways to eat healthy, but there are basic common things that are part of healthy eating. And we're going to talk about some of those in a second. One of the other questions that came up in the lead up to this presentation was around the idea of sort of anti-inflammatory diets or anti-inflammation diets, and, you know, what does that actually mean? And as much as I had an idea in my head what that might mean, it was very interesting to go and do a little bit of Google research and just see what comes up when you type in anti-inflammatory diet. But again, it actually comes back to healthy eating. So it's there's nothing necessarily too rocket science about it. And although it's potentially very tempting to say, oh, I must eat this food and I must eat that food and this food's better than something else, the reality is that it's the whole eating pattern that's the most important thing. The short answer, if we're looking to reduce the inflammatory load or reduce the effects of inflammation and essentially things that might oppose that, it's these sorts of things. It is your fruits and vegetables in particular, but you know, it's not one particular thing. There's no one perfect fruit or vegetable, or even other things. You know, things like onions and garlic and things like that are always in that mix, but so are all of your different coloured fruits and vegetables. And it was really interesting looking at this in terms of what people put out there on the internet, but there was quite a lot of overlap, to be perfectly honest. At the end of the day, the widest variety of foods, and particularly fruits and vegetables that you can get in, you are going to optimize the balance of the different nutrients that you get from these foods, but also the different types of anti-inflammatory sort of chemicals, if you like, that are naturally found within these foods. What we also know historically, and being a sports dietitian as well, there's always questions around reducing inflammation in the sense of injuries and recovery from knocks and things like that in athletes, that if you look at the supplements that are anti-inflammatory, or particularly high dose of some of the vitamins, they potentially end up being pro-inflammatory, which means they actually potentially make the inflammation worse. Whereas comparing that to a balanced diet with lots of fruits and vegetables and different varieties, that was the most effective way to reduce the inflammatory markers. So the bottom line is plenty of fruit and vegetables, nothing sexy, no one particular one, but lots and lots of variety. The other thing that's potentially important, and I put up the Australian Guide to Healthy Eating here, which is nothing new. It's been around for quite a long time, but it's meant to represent the balance across you know, your whole eating pattern. But one thing that's certainly potentially a benefit is to choose more protein sources that are plant-based, and they certainly have a slightly lower potential inflammatory response compared to animal proteins. So if there was one thing that I was going to say to people who have vasculitis, who are trying to control the inflammatory load, this is one thing you could do above and beyond just general healthy eating. So including more beans and legumes, lentils, in place of animal proteins like meats and poultry and fish and eggs and other dairy foods could be good. That doesn't necessarily mean being vegetarian or vegan. What it means is including these as part of that balance, because we know things like fish are good. We know that red meat's a good source of iron, for example, so it's good for other reasons. You know, so it's not about necessarily taking one thing out and then completely replacing it, but trying to get the balance right and giving yourself the best chance, basically. But there is quite a lot of evidence around plant-based eating and its effects in terms of controlling diabetes and blood sugar levels, controlling blood pressure, higher satiety, so it fills you up more, so that helps if appetite is high, and those things can certainly help with weight as well. The last phase, if you like, is where there's a relapse or whether it's just progression from the long-term effects of the disease, is you need to know your own individual needs. And I think that's come through in some of the previous presentations as well of, you know, there's not always the perfect answer. And to be honest, in these sort of situations, there's never just one condition. It's very rare that it's just vasculitis and affecting the kidneys. There'll be other things going on, and every single person has their own things that they like to eat, their own preferences. There may be other, you know, taste things. There might be other allergies. There might be other medical conditions that need to be considered in the mix, and that's very much what we do. And certainly an important point in terms of kidney disease is that having kidney disease doesn't mean that you're necessarily at the very end of the line and that the kidneys are completely gone, although that obviously can certainly happen. but it's knowing where you are on that spectrum that's really important, because if it's earlier on, the same messages I've just been talking about would be very appropriate. If it's end stages of kidney disease, then we're thinking about things like potassium and fluid and protein, phosphate that might need to be adjusted alongside all of the other things as well. So, you know, in this sort of situation, the best advice I can give right now is get on the front foot and do something about it early. You know, you should be asking your treating, you know, doctors, the people that you have looking after you in various ways, to get advice on who's the best person to talk to, get in, do something about it, get on the front foot, rather than waiting till someone says, oh, now everything's a bit far gone, but now we need to do all these things. When if we can slow down the progression, that's certainly what we should be aiming to do. So that's enough from me for now. Jess, I'm quite happy to open up for questions and see what was actually on the chat, because I wasn't following that.
Thanks, Anthony, for a great overview. I've got a question for you first. So people in, you know, the acute phase of their illness, how often should they be weighing themselves, do you think? Or if at all?
That probably depends on the phase, to be perfectly honest. That's not something we want to be focusing on heavily. In a normal situation, especially with steroids in the mix, I'll be thinking once a week is probably really important, because potentially if you leave it too long, we're not picking up that change, and then it becomes too late. And it's much harder to lose weight than it is to control it. So, you know, there are other things though that can give you an idea of whether you're still the same. You know, do your clothes still fit the same? These are pretty obvious ones, you know, or you happen to put your belt out on your pants. Those little, you know, how does your watch fit? Those sort of things are often clues. So it really will depend on the situation.
Oh, totally. And you indicated just how important to sort of exercising, and it's very different, different people's sort of capabilities. But what would be the general guideline in terms of, you know, how often, how much?
That's a bit like how long is a piece of string in some ways, but look, the general recommendations, if people are otherwise fit and healthy, so if we're thinking about remission, we're looking at you know, 30 to 60 minutes of relatively moderate intensity exercise. So that's not necessarily all out, but it is not just going for a stroll at the shops. And doing that 4 or 5 times per week, that has all the health benefits. If it's about weight loss, it probably needs to be a little bit more than that in reality. And variety is important, progression is important, getting proper advice from preferably an exercise physiologist would be my advice, more so than just a personal trainer or even a physio, because it's about getting assessed properly and working out what you're actually physically capable of doing.
Yeah, that's a term a lot of people might not have heard of, exercise physiologists. Do you want to just explain, you know, what that is, and how do people find someone in their local state?
Yeah, look, that's a good point. Exercise physiologists have been around for quite a long time, but not necessarily in the clinical space. But they are around more so away from hospitals these days in sort of private clinics. But an exercise physiologist is someone who really is an expert in the exercise side of things, who can assess things properly, who's got a lot more university training, a lot more sort of insight, and hopefully a bit more clinical insight as well. So you'll get a lot more individualized advice. So they are people that you can get referred to through Medicare as well, through the primary care programs through the GP, for example. But there are a lot around. What you really want is an accredited exercise physiologist, and these days they're commonly in GP practices and other places as well.